Well, first of all, I have to say good evening to everyone, and thank you for signing up in your time to listen to me talk. And it's a real privilege to be asked to talk to you about maternity subjects. And I'd just like to start with a bit of sort of warming your appetite, if I'm allowed to say that, when it comes to thinking or talking about breech delivery. Because my experience to date, working within an ambulance service setting, tells me that everyone that sees me walking in the corridors, or whether I'm out with the crews, that they're the one thing that they always want is a midwife. And so I felt very wanted for the past 18 months, but more so because it's certainly identified or highlighted to me that what we really need to do is ensure that we provide lots of opportunity for maternity updating, but not just that through PowerPoint, but also getting people out and exposed to training together so you feel really confident. And actually, when you're faced with maybe some feet coming out first, that you very politely relax, you have a wonderful smile on your face of confidence, and as you approach that mother, that she sees you and she thinks they're really safe and they know what they're doing. Even so deep down inside, you may be thinking, oh my goodness, when did I last update? So today's session really is about a sharing of experience, but also your opportunity to ask questions, and hopefully I'll be able to answer them for you this evening. And just a bit of background for you so you can understand my context. I've practiced as a midwife in the countryside, in inner city London, out in rural Derbyshire where I currently live, and I also practice still as a community midwife, and I go on call for home births and BBAs. So I have some real hands-on practice of emergencies when they go wrong, or when they occur, should I say. I've practiced for about 25 years as a midwife, and I've been employed by an ambulance service for the past 18 months as a consultant midwife advisor. And my remit is to look at the 27 maternity services that we cover, and actually look at the training and look at the challenges that we all face in the pre-hospital setting. So I have to say I'm really excited to talk to you about breech, and at the end of it I'm hoping that you come away with some joy in your step, and you look forward to the next time you get a call and you think it's a breech, but hey, I'm going to go in with some confidence. So let's see if we can achieve that tonight. So moving on, just imagine now, and I'd like you to go to a place in your mind. I know this could be very painful for some people to go to, but consider that you, on your mobile data terminal or on your screen, it comes up and it says you're going to be dispatched to a 30-year-old female. She's in her 3rd trimester and the birth is imminent. Now, for quite a lot of people that I've met in the past 18 months, they've told me that births either go really, really well, or actually they can often be quite catastrophic. The middle ground seems to be one that's really quite difficult for most of us to sit in. And that's often because women are calling an ambulance for a reason, and generally that's not always that things are going right. It can also be that it's going wrong. But a lot of the time we don't necessarily know it's breech, and that's a big challenge for all of us. And certainly if you've never attended a birth where there's a breech, or you work in a part of the country where you don't have midwives routinely attending births when they're called to attend, this can be extremely stressful. And I just want to pause us there, and I want you to think about how you personally feel right now, that if you go on shift, maybe tomorrow morning, and you get this on your MDT, or those of you amongst that are listening in at the moment that may be pre-hospital doctors, that actually you turn up and you're presented this. I want you to just think about for a minute what's going on in your mind, and do you feel adequately prepared? When was the last time you knew what to do or felt safe about approaching this? And I'd like you to just think about that and hold that thought, and I'd like to explore that with you at the end. And in reality, what we do know is that at term, or after 37 weeks of pregnancy, that about 3 to 4 babies out of 100 will be presenting with their bottom first, or their feet. Sometimes that might be a foot, it may be feet. You may notice the cord is coming down and it might tell you or suggest that the bottom's coming first. But that rate, although that may not seem a lot at term, as you get younger and younger in terms of gestation, if you like, when you look at about 28 weeks of pregnancy, then looking at about 20% of babies will be in a breech. So the likelihood is in our lifetime, more so as ambulance staff, that we will come across a breech presentation. And I would like to say that I've only delivered a number of breeches in my career. They've all been in hospital. They've been with women on a bed, hanging on the edge of the bed, with a lot of people involved. So going into an emergency with an unplanned breech can be extremely frightening and actually very, very stressful for everyone involved. And that's not excluding those family members that certainly, if they've called up, they're not quite sure what's coming out. They thought it was a baby's head, there's feet. So you can imagine the situation you're going into. So before we move on, I just want to leave this with you. What do you do? Do you do what's on the left-hand side of the screen? Do you keep calm and Google it? Do you think, actually, hold on a minute, let's go on to Google. What does it say in JR Calc? Do you phone a friend? Do you think, actually, I'm not quite sure what to do here? Do I need to ring my emergency operations centre because I'm not quite sure about this? Now, this is going to be particularly frightening if you're the first responder on scene, if you're a solo paramedic, or perhaps you're like one of our colleagues in London who turned up on a motorbike because he was the first available resource that could get there very, very quickly and was faced with a baby in the process of being born. Or actually, like the lady at the top looking rather panicked, but actually inside you're thinking, what do I do? What do I expect? I haven't been to a maternity job. And bear in mind the context that as midwives and obstetricians in a hospital setting, we're used to training hands-on skills every year. So if even I haven't delivered a breech for a number of years, I'm still expected to practice it and be conversant with it and know what to do in an emergency. And that's no different to our ambulance staff and the staff that I work with. And part of the work that I'm doing with our teams is to ensure that actually, if you're out there, you've been exposed to joint training with midwives, so you get a hands-on feel of actually what it is that you need to be recognising as normal and how you recognise when things are not going normally, and what, if there is a delay, how do you manage that? Because the best outcome we want is you recognising when it's normal and keeping your hands off. So we've thought about what we're going to do, and that's really important, because what I want you to be thinking about is, okay, so this is a breech birth, the baby's coming bottom first. What do I need in this situation? How do I prepare? How do I go in with that smile on my face? Like Amanda has said, go in confidently, relax, and think, how can I really manage this? So I hope in the next couple of slides I can really give you some real top tips that comes out of experience as a midwife, but experience of the pre-hospital setting. And that's absolutely critical here. So, what do you need? Well, at a breech birth, there's actually very, very little you need. Not necessarily any different to what you do at a birth that was occurring with the baby coming head first. But probably most importantly is a maternity pack. So if you have nothing else, having some gloves on and a towel is probably the most important thing. So you can see the maternity pack on the left. It's got an Inco pad there and it's got some clamps, but ideally you want your gloves on. And in the middle, I've got this lovely, cute baby, which hopefully is what we're going to have at the end of the presentation. We're going to have a nice baby that's come out bottom first and is very thankful for you, for your patience and your smiling face, imbuing confidence in the mother, whilst underneath you might be sweating a bit. So ultimately, what we want to do is we want lots of our warm towels, and we want to think about the environment in which this baby is being born into. Because as we'll see from the pictures as we move forward, a baby that's being born with its bottom first is going to be delivering its body, it's going to be birthing itself. But what we often find very difficult is the sight of seeing a baby hanging from between a mother's legs, whether she's on all fours or whether she's sitting on the edge of the bed or whether she's squatting. and the sight of the baby's head inside the vagina. And that can be very frightening, not only to crews that go on scene, but obviously a woman, a couple, a family. And as you can imagine, if you go into that kind of situation where you think, what is going on with the baby? You could have family members around, you could have other children. And often managing that situation can be incredibly complicated, particularly if you turn up and you're the first responder on scene. You're managing a very anxious situation, but you're potentially managing possibly relatives that have been pulling at a baby. And we've certainly had cases in the LAS where that was a case where crews had gone on scene and the baby was being born, and they'd actually been trying in their fear to try and deliver the baby. So what we do know is that keeping this baby warm while it's being born is absolutely critical. So towels are your friend, and getting somewhere warm where you can warm the towels is absolutely critical. And that means even if you're out in the street, you need to find yourself somewhere safe where you've got somewhere warm to put that towel. And even if that means you put it down someone's top or down dad's shirt, where actually the warmth of the towel can be ready to dry that baby off and wrap it. So we've got a nice happy baby in the middle there. That's what we're looking for. That's what I'm sure you want to see at the end of this experience, that we've got a happy smiling baby gurgling away, breastfeeding nicely with mum, keeping nicely warm while you sit and breathe a bit and take stock of what's just happened. On the right hand side of the screen is our paediatric kit, is our bag valve mask. We've got the gloves there, we've got some airways. And that's because as we're moving on, we're going to think about what is unique about this breech birth that we've got to consider. And that's absolutely critical, because one of the things that we know can commonly happen is when baby's being born bottom first, is that there may be an increased likelihood that one, the baby's going to need resuscitation, but also that it may be more vulnerable to being cold, simply because that body has been hanging out potentially a few minutes before you arrive on scene. And when you arrive on scene, front doors get opened, cold air comes in, and if that mother isn't in a very warm environment, then already you're dealing with a baby that's cold. And we know that babies that are cold can take a little longer to get those inflation breaths really going and really holding those lungs open. So, moving on. We've thought about what we need, and as you can see, you've got a maternity pack, you've got your towels, and you've got your resuscitation equipment ready for this baby. So just on that note, before I move you along, we've recently done a piece of work around looking at the maternity kits, and we're hoping to launch a national pack that will include 2 towels, because there are some ambulances services across the country that don't necessarily have the kit that would enable to keep that baby warm. So let's have a look. Let's think about how you're going to make it safe for this baby. So the baby's coming out, and as you can see, this was a picture taken yesterday. It's also on the Facebook page that was at the front of the presentation, which I'll refer back to later on. And as you can see, when you've got a baby being born and it's coming out and just hanging there with gravity enabling the body and the head to be born, you can see that quite a large proportion of the body is exposed. So I want you to think about the 3 C's. The 3 C's are really easy to remember. I want you to think about cold and how you're going to change that environment so it's a warm one. And the environment should be warm enough for you to feel comfortably uncomfortable. You're feeling quite warm and you're a bit hot under the collar. And that's not just the stress of the situation, that's thinking about, actually, this is getting quite warm in here. And if it's getting too warm for you, then that's going to be nicely warm for that baby. And by keeping it warm, we're trying to reduce the effect of a very cold baby being warm, because what we want to do is, once it's nicely warm, we want it to breathe spontaneously within a minute of birth. That's what we want to see. And ultimately, a very, very cold baby is not only going to take longer to warm up, but we know with a temperature drop in a baby, the risk of the baby dying increases. So this is really significant. So the first of our 3 C's is cold. We're going to manage our environment. We're going to close the windows and the doors. And certainly a couple of the BBAs I've been to over the years, I've walked in at 4 in the morning, the mum's on the kitchen floor, the crews are on the kitchen floor, we're all on the kitchen floor. You forget in the blurring of the situation that what you can feel is the coldness of the floor. But actually that's something really important as we're dealing with situations, to think, actually, I need to make sure this temperature is nice and warm. So close the doors, close the windows, ensure that mother is nicely comfortable, and protect the area where that baby is. So the second one of the C's, of the 3 C's, is compression. While our baby is being born vaginally, you're going to notice that there could well be a lot of meconium, because you can imagine as that bottom is being squeezed during the process of birth, the meconium is going to be squeezed out of the baby's anus. So there is not only compression going on of the baby's body, but there's potential for compression on the umbilical cord. And that means this baby is far more at risk of hypoxia. And so that preparing for the resuscitation, setting up a neonatal area, is absolutely critical. If you walk in and that baby's being born, yes, you are going to request a midwife if that's custom and practice in the area that you work, because you'd like them to be there to help you and support you. But also you're going to make sure that you've got your backup crew available and escalate that if need be. So you may be considering having a separate ambulance on standby, because shortly you're going to have 2 patients, not just the one. So the compression is really important, and we've got to think this baby is more likely to need some degree of support with its airway and breathing when it's born. And so the best thing you can do in this situation is think cold, think compression, I want to be ready. And if need be, if you're a first responder on scene, then delegate the task to a dad to just make a clean area with a warm towel where you can set your kit up until your backup turns up on scene, and then you can delegate the task to them while you focus on catching this baby. And note there that I talk about catching the baby, because actually what we want you to do is be as hands-off as possible, and I'm going to talk about why. So the last of your 3 C's is compromise. And as I've mentioned earlier, a combination of the body hanging and the compression potentially of the umbilical cord means these babies can become compromised quite quickly. And so recognising how to minimise compromise is key, and we're going to talk about that in the next slide. But you must anticipate that this baby may well need resuscitating. So if you manage your cold, you're aware of the compression on this baby, and you're aware of the compromise, then you can plan ahead for good management. And that really is the key to this, is about good organisation when you enter that premises and think of your 3 C's. So moving on then, let's have a think about what's happening. So for those of you who have been able to look online and watch YouTubes, because nowadays everything is available to watch, and there are some really good natural breech births, and I would recommend that you have a look at one particularly, which I've posted on the Facebook page, Joint Maternity Training on Facebook, and there's a link there to a very, very beautiful breech birth that takes place, and it shows you the normal mechanism. And what I want to talk through here on this slide is, well, what's actually happening? What's actually going on here? And on the first slide, what you can see is that the mum's got her bottom facing us, she's got her back to the camera, and the largest part of her pelvis in this position is what we would call the anterior-posterior diameter, or front to back. And the baby's pelvis, if you look at it, the front picture, the first picture shows us it's actually the side of the baby and the buttocks are coming down. And the baby's, the side from one side of the pelvis or the side of the hip to another is actually presenting the widest diameter of the pelvis. If the woman's on the edge of the bed as an example, you'll notice that the buttocks will rise up as they extend the perineum. And that's really important because it's certainly going to stretch the perineum as the baby's buttocks are being born. Now, the first breech that I was really fortunate to attend was a lady that was in an operating theatre. She was wandering around naked very happily, and as is quite customary on labour wards, the lady got up onto the operating table when she wanted a push, and as she got onto the table, the buttocks presented. The husband was at the head end with her, giving her lots of support, and as she had her bottom over the edge of the bed, the buttocks presented, and lo and behold, the willy or the penis presented between the buttocks as well, and out came a lots of urine as the compression on the baby's body caused it to wee everywhere. And as you can imagine, there was roars of laughter in the operating theatre and a lot of relief, because what we were expecting to see, and we did indeed see, was progress being made as the baby wanted to be born. So hopefully you'll be able to laugh at your next breech delivery rather than the frightening feelings that we often have. So in the second picture, you can see that the midwife in attendance has her hands ready, and really we don't encourage touching, because what we don't want to do is stimulate this baby. Stimulation not only can cause the baby to extend the body that's already in the pelvis, but also potentially any touching, potentially even with the cord, can cause it to constrict. And we are assuming that the baby's still getting some oxygen through the umbilical cord at this point. And the first thing that we're looking to be born are the baby's legs. And you can see in the second picture, the first leg has delivered itself, and the baby's tummy, or the baby's tum, is towards mum's bum. And if you can remember tum to bum, baby's tum towards mum's bum, that's the position that we're always being mindful of. And that's going to remind us to keep sitting on our hands and keep our hands off. And that's telling you everything is normal. And in 99% of cases, the legs will deliver themselves. Very, very rarely do you need to do a manoeuvre to assist them to be born. And that's really important, because the whole ethos of a breech birth is that actually we are sitting on our hands, and unlike other jobs that we go to in maternity where we intervene, a breech birth is very much about the art of not intervening and observing. So in the third picture, you now have the view of the baby that's born, and it's heading up towards the armpits of the baby, and you can see what looks like a little boy there. You can see the umbilical cord stretched up, heading up towards probably the chin of this baby, and you can see the midwife ready with her gloved hands, the body's hanging nicely there. And at the moment, the arms are likely to be extended upwards, and as the baby's negotiating the pelvis, we would expect those to navigate down. And that baby's in an absolutely beautiful position to navigate through the pelvis. So in our last picture, what you can see, that head's coming down, and at this point you'd expect, if you could see through the rectum there of that lady that's presenting to the woman, the baby's face would be looking directly at the midwife and hopefully smiling, apart from thinking, please get me out of here now, I'm ready to be born. And the arms should spontaneously birth, and that's what we're looking for. So we're looking for spontaneous birth of the legs, spontaneous birth of the arms, and in this position, the head's got lots of room to come round and sweep the wall of the vagina. And you can see the midwife's literally going to support. You often see the baby being supported under the armpits, or just about to support that head and chin as the baby will come out under the weight of its own body. So there you have it. Nice, normal breech birth. It does happen, and it can happen. But the key is to actually recognise when this is going normally, and the key to success is promoting gravity. So at the moment in the ambulance service, and in the majority of labour wards that we see around the country, breech births tend to occur in a position where the mother is either on the edge of the bed and encourages the body to hang down, or we see women birthing their babies in an obstetric theatre with the mum's bottom over the edge of a operating table where the body can be allowed to hang. And many of us in the years that have caught babies being born by the breeches, and certainly on one occasion where I had to gently pat the hands of an obstetrician who was going to go in and help with the baby coming out, is a reminder to all of us that the art of a breech and keeping it safe and successful is to ensure that you're prepared for the baby coming and that you may need to resuscitate, but recognising when you may need to intervene even rather than interfere, and as some people would say, it is probably interfering. But as you can see in these pictures here, what we want is allow the hands-off approach to the breech. And a lot of the jobs that a lot of our calls that our staff to go to when they've had breech births, the women have either been on all fours or they've been upright. And actually, we will see our guidance, our national guidance, which is being reviewed at the moment, will likely change to encourage us, or certainly to support us if we're faced with a woman on all fours, the landmarks we expect to see. And again, on all fours, you'd expect to see the baby's tum facing mum's bum. So just remember that nice little saying, baby's tum towards mum's bum, and you'll be on the right path. So we're looking at being hands off, but actually in reality, what are we expecting here? What are the time limits? You know, what are we expecting to see happen? Are we waiting for contractions, or ultimately are we waiting for, if nothing's happened after 5 minutes, when do we intervene? And what's of note is that actually the evidence out there is very, very unclear about the optimal time. But certainly from discussions with peers and obstetricians, you generally want to see from the delivery of the body to the birth of the head, generally 5 minutes can be a max. Some people see it a lot quicker. And what you're looking is for evidence of progress, and that's absolutely critical. So the next slide talks about skills and confidence, because the skills that we talk about in relation to recognizing when there is a delay requires learning technical hands-on skills. And those skills are very much beyond the scope of doing a PowerPoint. And I've got some recommendations at the end of this to help support you with getting those skills. But for the purposes of mentioning it in the context of this discussion, the first point at which we would say that we may need to do anything with our hands, and there are 3 of them, are 3 landmarks to consider. So we mentioned earlier that the legs very rarely do not deliver themselves. But if the legs are delaying the birth of the baby or the progress, then what we do teach people is that you can put a small amount of pressure on the back of the baby's knee, lift the leg up, as in this diagram, A and B, and you literally just scoop the baby's leg out. And you may well find as that allows room for the baby's legs to come out, the second leg will naturally come out on its own. And you may find that just enables progression of the body to continue without you having to do anything else. But once those legs are born, you need to go back and sit on your hands and wait for that progress to be observed. So the next landmark that you're looking at in terms of any intervention would be looking at the back of the shoulder blades, or you're looking at the birth of the arms. And so if the arms haven't birthed themselves spontaneously, what we would then look to do is using your hands on the back of the baby's pelvis, as highlighted in the picture on your screen, is very, very gently, without any undue pressure, you're just holding the bony pelvis, you would lift the baby up and rotate 90 degrees and just allow the arm to drop out, and then do the same on the opposite side, rotating another 180 degrees. And once the arms are born, you're going to let that body drop down and allow that gravity to continue the birth of the baby. And then lastly, and ultimately in reality, what you then will find is the head will very nicely come down, and all you should really be doing, and this is a picture with, you can see my hands on this baby here, where this is one of our trainee babies, so it's an inflatable doll, so I do apologise if it looks a bit odd, but what you can see is I've got the baby's body resting very nicely on my arm, so the baby would be facing downward, if you like. I've got the baby's back uppermost to the mother's abdomen there. This is one of our tutors demonstrating this, and the baby's sitting, if you imagine, or lying face down on my arm, and I'm just allowing the baby's weight to drop on my arm as that baby's head is just born and it comes out of the vagina. And then I can very, very nicely and gently hand that baby to the mum, where we can put it onto mum's warm chest. We can dry the baby, and we can start assessing that baby and giving that baby a full minute to start breathing, while we then we can look at the cord and feel it, and we can assess the picture to actually decide whether what we need now is to install any resuscitative measures. And at this point, this is a really important time to think about, while I'm assessing that baby, even if I don't automatically clamp and cut this cord, that additional pulsation of the umbilical cord actually is conferring benefit to this baby, because we know it's more likely to need resuscitating. So finally, as I move on, because I think I'm going to open the questions shortly up to you, what are your challenges and what have we got to think out here? Okay, because breech birth, attending a breech birth and feeling confident and skilled is about you having training that is reflecting those technical and non-technical skills that you need in that situation. And that's the same that's true of whether we work in an ambulance service as clinicians or whether we work in the acute setting. We still need to practice those skills. So a couple of pictures for you, just to highlight what we do in the London Ambulance Service, and we're hoping to extend that out to West Midlands with one of my colleagues and peers, Amy Yarrington, who's a training officer and a midwife, is that we're very passionate and committed to really rolling out multidisciplinary training to all the ambulance staff. And that's something nationally we're very committed to and are really promoting. So on the left-hand side, this is a group of our advanced paramedic practitioners here in our birthing pool, because we teach emergencies in pools, in tents, in ambulances, wherever we can get space, we will run them. And what you can see here is a group of our advanced paramedic practitioners. But while they get particular training on it, we also offer a programme of joint training where our crews and midwives, pre-hospital doctors, we join together and we run the simulation and scenarios as a team. Because what we do know is teams that play together function much better in a situation where there is an emergency. And actually, you're more likely to communicate much more effectively together, particularly when it comes to your midwives on scene. Excuse me. Second picture in the middle, as you can see, this is in one of our training rooms, and one of the midwives showing with the crews about how they'd be supporting a breech delivery. And you can see at the moment it looks like one of our staff is delivering the breech and doing a rotation manoeuvre. And then up at the end of the screen on the far right hand side is some of the training that we've done with our staff and the midwives in South London in the home setting. So we try and mirror the setting in which you're likely to encounter some of these challenges. So finally, I've got a message out to you before we start asking questions. Thank you. Just been given a glass of water. I want you to think about, for those of you that don't work in London, because we run a very comprehensive programme at the moment, I want you to think about contacting your local maternity unit, and I'd like you to challenge them and really spearhead getting involved in annual updating skills and drills. And all maternity unit run these. We're about to run some in one of the ED departments in London because we want to engage people in this way and ED staff. I want you to contact your local practice development midwife, and I want you to say, we need training together. This is part of safety. It's about safety of mothers and it's about safety of babies. And in that way, what you will start to do is you start talking the same language, because we talk very different languages on occasion, but we start to understand where we're coming from in our different spheres of practice. So I want you to start a revolution after tonight. And if anyone says who said, you can say Amanda said, but I want us to start shaking this up, because I want to enable all ambulance services to offer the staff and the team, whether they're ED doctors, whether they're paramedics, whether they're all our ambulance support staff, we need to look to how we safely deliver MDD training. I want you to contact your education lead. I want you to contact the ambulance service education lead and get them to run a maternity event. Get them to run some skills drills. You know, start pushing for this. We really need this. And the more we start shaking, the more likely we're going to get some action. And I've already engaged with the ambulance chief executives. So let's start getting that action and that shaking going on at the bottom and at the top. And lastly, but not leastly, ask your ambulance service to run some simulation sessions. And we know a number of ambulance services have sim labs, have simbulances. So there's lots of resource there, and we need to tap into that and we need to share. So I'm going to open the arena up for questions, and I'd just like to thank you for listening. So I will ping this back to Andrew.
Thank you very much, Amanda. Do you know what? That is really useful. I've been a paramedic for nearly 15 years, and I've learnt some fascinating things tonight because, as we've discussed before this webinar, breech births are some of my worst nightmares. And when I see midwife frantic listed at the front door waving me in, I'm not sure what I can bring to the conversation really, apart from driving very fast and offering some resuscitative advice. But what we'll do, if you have got any questions, I can see that Rod's already asked a question. and I'll read that out in a second. But if you are happy for us to open up your microphone for you to ask Amanda a question live, just simply pop your hand up now. Ensure that you're in a nice quiet room with your laptop or your computer, and I will open the microphone up so that you can ask Amanda the question. And I can see that Rod has done that straight away. So I'm just going to connect you, Rod, and then you can ask Amanda the question. Hopefully you'll be able to hear us. Can you hear us, Rod?
Yeah, I can hear you.
And Amanda should
Hi,
be able to
Rod,
hear you.
how are you doing?
Yeah, very well, thank you.
Welcome.
That was a really good talk. I'm particularly interested because I'm not a doctor. I'm a sort of I'm an offshore medic come paramedic, and I train ship's captains who work at sea. One of the parts of the course is emergency childbirth, and one of the questions always comes up during an emergency childbirth, whether it's breech or not.
Yes.
Is at sea. When would they give things like vitamin K and oxytocin?
Right. Okay. I mean, for the most part, an oxytocin drug, we would offer routinely once the woman has birthed, but we would use it as a part of a package called active management of the third stage of labour, which is the delivery of the placenta.
Yeah.
And we use that to speed up, if you like, the placenta coming away from the uterine wall. And we use then, you may have seen this, some of you may have seen this done by a midwife, where she places her hand over the mother's abdomen, just slightly above the pubic bone. And we do something called controlled cord traction. So controlled meaning that we will very gently deliver the placenta. And what our hand does is, by guarding the abdomen, we're trying to prevent, if the placenta is still slightly attached to the wall, that we don't cause an inversion of the uterus. Now, once we've given syntometrin as a drug, we then do this method. But actually, over the years, we've used syntometrin without necessarily doing that in the past. And syntometrin, or oxytocin, is certainly indicated in reducing the quantity or volume of blood loss. So when you use it in a large population of women, it significantly reduces up to about 60% of women that have a blood loss above 500 to 600 mils. And so by using an oxytoxic, you're having a prophylactic effect if you used it routinely. But also what it does do is it have a reasonable half-life that means that you can keep that uterus contracted. So from our point of view in the pre-hospital setting, we don't use it routinely, as you're very much aware, because our sphere of practice from paramedic practice is within the sort of, for a PPH, a postpartum hemorrhage, or up to the first 24 hours. So in that case, using an oxytoxic, if you're concerned about blood loss, it's more than 200 to 300 mils, or you are concerned, then it would be reasonable to use an oxytoxic drug.
Right.
Does that answer that, Rod?
Yeah, it does. Yeah, because obviously they would not normally have heavily pregnant ladies at sea, but occasionally, only occasionally, they do have ladies at sea who don't actually know they're pregnant, and then there's a prem birth or whatever it is.
Right. Right.
As happened last year, a ship came across a yacht with a lady on board heavily pregnant.
Right. And did she birth at sea, or?
They were both birthed at sea, both normal deliveries, and there was no problems.
Wow. So a new meaning to water birth then, Rod?
Well, that's explained to them, but yeah, it's a new meaning to it. The other question I put on there, it used to be that we were taught if the air was compromised with like some meconium, do you still vigorously aspirate or not?
Well, do you know what? That was the advice that used to be given. But what we do know now, if you come out and you've got a vigorous baby and they're screaming, the fact that they're screaming suggests that they've got some really, really good ventilation having taken place. And generally when they're screaming, what they then have done is effectively opened those airways up, opened the lungs up, enabled that surfactant to really keep those lungs nicely opened. So if you've got a baby that's vigorous and crying, it's dealt with any meconium that might be in the airway itself. You are more concerned about the baby that's coming out apneic, white, pale and floppy, and you've got thick meconium. And in that case, that is where you need to inspect that airway. And if you can see meconium present, using a method of visual inspection, then gently suction it out. But what you don't want to do is, if you do have a heart rate on a baby, is start probing around in the back of the throat and actually cause a worsening bradycardia. So most babies that are born that come out vigorous, you don't have an airway problem. Baby comes out and is in very, very poor condition. Even if you haven't seen thick meconium, then part of that airway assessment is going to be opening up the airway, isn't it? And actually looking inside, and is there anything that's likely to stop me then? Because if actually you can't see anything, then you're going to move on to giving those initial 5 inflation breaths. Does that help, Rod?
Yeah, that's great. Thank you very much.
Wonderful. Thanks so much indeed, Rod. Thank you. Okay, we have another question from Sean, and Sean would like to know, Amanda, various trusts advocate different thinking on cord length. If we need to travel 2 to 3 inch or 6 to 8 inch, which is preferred?
God, do you know what? That's a really, really good question. I think this is very much relevant to preemie babies, where if you've got a baby that's need resuscitating, you know, ultimately as we go down the A, B, and C, the D is really one that we're going to be doing in the ED department. So having a reasonable length between sort of, you know, I would say, I'm just thinking in centimetres here, you might want to leave a sort of a good 6 centimetres and use 2 clamps, so at least they can cut one off and then use the umbilical vein catheter to actually then give drugs if need be. So you're not going to be told off for leaving an unreasonable length as long as there's a significant length there. So, you know, a couple of centimetres away from the actual entry of the umbilical cord to the abdomen and the baby.
Wonderful. Thanks very much. Oh, that answers your question, Sean. We have got another live question from Hannah. Are you there, Hannah? Can you hear us?
I can.
Okay.
Hi, Hannah.
Hi.
Hi, Hannah. How are you doing?
Yeah, really good, thank you. It was a really awesome presentation. I'm quite new to this. I'm an advanced tech as opposed to a paramedic. Just a couple of questions. So you said obviously to leave the baby alone for a minute to allow it to spontaneously breathe.
Yes, Hannah, you may need to speak up a bit because you sound quite distant. I just don't want to make sure I miss your question.
Oh, sorry, is that any better?
Yeah, slightly better. Yeah, fire away.
Perfect. So you said to leave the baby for a minute to breathe spontaneously. Do you just leave well alone for that minute, or would you sort of assist with breathing and then hope that they kind of take over spontaneously?
Yeah. And if you, I mean, this would be a challenge to not only yourself, but, you know, our colleagues here. A minute can go really, really quickly. And what you'll be able to see is that, you know, while the baby's born and you've got that minute, you know, you're drying that baby, aren't you? And you're rubbing that baby, and you're doing that visual assessment, aren't you? That assessment of baby's colour and tone and response and heart rate and breathing. So that minute is really, really important, because that's the time when that adaptation is going on. And we often think, you know, baby comes out and it immediately needs lots and lots of stimulation. But what you don't want to do is a baby that's actually going to start breathing on its own, making it worse by literally going in. So be mindful of how quickly you intervene, but give baby enough time to start making an effort on its own, and you'll be surprised how quickly they do that. But what's really important is dry the baby and rub it, and then you'll get a sense of what needs to be done. So even if the baby comes out, you've dried and rubbed it, you'll be surprised how 20 and 30 seconds goes really quickly. But when we talk about doing something for a minute, it feels like a long time, doesn't it?
It does.
Yeah, I know. Anyway, when you've got a baby, you think, oh, gosh, what's happening? And we often find that as midwives. And when you look at a baby that's born, even when it comes out head first, babies are not pink and rosy when they come out. They're generally purple, yeah? So giving that baby time to pink up and respond, particularly if you've got a lovely warm environment, will enable that to happen.
Brilliant. Thank you very much.
Is that helpful, Hannah?
Yes, very much so. Thank you.
Hannah, thank you very much indeed. Thank you. Lots of questions coming in for you here, Amanda. Brian has asked, are the poet and prompt courses worth doing in addition to an update training you mentioned earlier?
Okay, so that's a really, really good question, and I suppose it would depend on the background. I think a prompt course at the moment is designed for in-hospital delivery, although the prompt team are looking at a pre-prompt. I've just qualified as a poet instructor, and I did poet when I first joined the ambulance service. And I think doing a course that's designed and it's facilitated by people that are pre-hospital practitioners is critical if you're going to get that understanding of how we receive jobs in the ambulance service, how we deploy additional resources, the times that it takes to extricate people. That context is really important when you're facilitating learning, and I think that you'll find that more commonly in those courses that have at the heart of that a facilitation with people that are accustomed to facilitating in that kind of environment. And poet would certainly be one of those. The pre-prompt, I've approached Tim Draycott and his team down at Southmead. I was with one of their representatives today at a meeting this morning, and I suppose I'm awaiting an overview of what that would look like in its delivery, and then I would probably be able to answer that. But what I would say is what's critical at the moment is that there are courses out there, and obviously poet being the one that we, from an ambulance service point of view, we really look at, is that we also need to drive forward that part of the employer's responsibility as an ambulance service to its staff is it provides hands-on maternity training as a minimum standard, and that's one of the things I will be pushing with all the chief executives and the medical directors. So watch this space, because the benefit of one person going on a poet course, unless they're in a facilitation role, means that it's restricted to that person. Whereas if we can get a culture in an organisation of this learning, it's shared. So does that help with that question?
Hopefully, I think that will answer the question for you. If it doesn't answer the question, Brian, then simply just pop back underneath, and we'll address that.
Yeah, please do.
Okay, we have a question from Matthew. A very good question, I have to say, Matthew, because it was one of the questions I was going to ask towards the end. How long would you remain on scene with a breech birth before transporting to hospital, and what are the key warning signs indicating transport?
Okay, that's a really, really good question, and I just want to clarify that if it's the breech birth where you don't have a midwife attending, that you're on scene in an area where they don't send midwives, would that be a reasonable assumption to answer the question from?
I think so. Yes, I think that's what Matthew's trying to say.
Yeah, cool. Okay, so what I would expect is that you call for assistance, and you'd expect to see normal progress happening. Now, what you will think about is ultimately we want to aim to get you to a situation where that baby is born and then you can resuscitate it if it needs be. Now, I don't want you to have to resuscitate any babies, obviously, but transporting a baby that's half in and half out is really problematic, because we know we go to maternity calls that are in very different settings, and the longer the baby is out and the longer that head is in, we know that the likelihood of there being maternal morbidity and mortality is going to increase. So it may mean that your question is about how long do you stay on scene. You stay on scene until you've delivered the baby, and then you would, obviously convey as soon as possible. But if you cannot get the head out, I would be asking you to ring your local maternity unit, speak to the most senior obstetrician. If you have a on-call medical director in your ambulance service, speak to them and ask them to guide you through how to deliver the head. Now, we have had a number of cases where women have birthed, particularly when they're premature babies, where the head has been caught in the cervix, and in that situation that's very, very difficult to manage from a point of view of a paramedic and even a midwife, So in that situation, you would just have to go. There's just no way. If you cannot get the head delivered, you can't get it delivered. But ultimately, what we want to do is enable you to be able to support that head as it's being delivered, so then you can manage that baby. But once you recognise there's a problem with the head, if you're not getting any response from either a midwife talking that through or someone in your control room that's got the expertise to say, right, this is what I want you to do, and that may be just changing the mother's position. Certainly midwives that are used to delivering lots of breeches, they recommend that if the woman's on all fours, you get her into a praying to Allah position. They use that terminology to describe the position of the woman having her bottom in the air and her head right down onto her hands. So it changes the shape of the pelvis to enable that baby's head to be delivered. So that it's a complex question because there's no right or wrong answer, because ultimately you want to try and enable the baby to be born spontaneously. But we've certainly had 1 or 2 cases where it wasn't possible, and it was only when they'd put the mum in the ambulance that by the time they got to the hospital the baby's head had delivered itself. But this was quite a period of time from the birth of the actual body, and the outcome was poor in that situation. You're more likely to be challenged when it's premature because the body can come through an unfully dilated cervix, so the chance of the head being trapped is theoretically much more possible than one at full term. So, yeah, staying on scene, as much as you can, stay on scene, deliver the baby, but if you need to then use those manoeuvres, and this is where going to your local maternity unit is really key, because then we can demonstrate those hands-on skills of how you can use your hand to flex the baby's head down and then enable it to be born.
Good
Is
question.
that helpful?
I think that answered the question very well. Thanks, Amanda. Hopefully that answers your question, Matthew. If it didn't, bob back in the bottom again and we'll try and address anything that we missed out.
Yeah, absolutely.
Good question from Andrew here. If there's a lack of progress identified and or we're worried about the compression of the cord causing potential hypoxia, would we ever get hands-on to assist or even assist pull gently to guide and encourage the baby to make progress? Maybe en route, as we identify the lack of progress, get to hospital. Anything we can do to help when there's a lack of progress of baby coming?
Okay, so if you've gone to a call where the baby's birthing, majority of the time, and I want to give context here, most breeches will deliver spontaneously. So if you go in with that approach, you're likely to see that happen. If it's not progressing, let's go back to those 3 landmarks of success. The legs very, very rarely need assistance, but if you're seeing that as the delay, use your pressure point at the back of the knee, or some people call it the popliteal fossa, but very gently. If you try it on yourself after this webinar, when someone presses you behind the knee, you generally flex your knee and adduct your leg like a frog for the sake of a description. And so this is what we would suggest you do, and this is what we teach on hands-on skills. So you flex that leg up and you may find everything comes next. So your legs are your first point of delay, if you like, although it's very rare. Your second delay are your arms. So we're going to think about lifting the baby's body up from its hanging position with our hands on the back of the sacrum, and we're going to rotate the arms so they deliver, okay? And then we're going to enable the body to just hang down again. The next thing then would be the head. So if the head is that delay, then like we talked about earlier, we're actually going to use our fingers very, very gently on the back of the occiput, and you'll see in some different pictures, and we talk about it in POET course as an example, and the POET online, that we would place 2 of our fingers on the baby's maxilla bones, and we're literally flexing that head and encouraging it out of the vagina. So those are the 3 manoeuvres that are going to manage your delays. If that fails, and actually you've got a distance to get to your nearest obstetric unit, then absolutely, if the woman's in a really nice upright position and you've got a nice open pelvis, then actually then you do need to think about conveying. If you have no one else to support you, you need to extricate quite quickly. But the simple recognition of the landmarks to allow that progress to happen are why we teach them, because they may well resolve your problem without you then having to get in an ambulance. We would much prefer you to be able to deliver on scene, because then you can manage, one can manage mum, you can manage baby. Okay, I hope that's okay.
Thanks so much indeed.
It's very difficult describing manoeuvres on a PowerPoint when probably when you're face to face, it's much easier.
Perfect. Just a compliment from Gareth. He says, not a question, just a comment. Thank you to Amanda for a really great presentation tonight. So I said I would pass that on to you.
Excellent. Thank you, Gareth. Brilliant. Good to
Question
hear it.
from Beverly. Good evening. Thank you again for all this information. I have always presumed that a breech birth is more painful than a normal birth. As a paramedic, Entonox does not seem enough. Would you recommend anything else or just stay with Entonox?
No, I mean, I think it's a really good comment, and actually, the uterus causes the pain, so and the stretching on the perineum. So it would suggest that irrespective of how you deliver, whether that's baby's head first or bottom first, the pain is, one would suspect, similar. However, it could be that the fear exacerbates the pain perception, particularly if it was an unplanned breech and you've got people coming into your home and you don't know what's going on. So I certainly think it's something about offering that choice to mother. I certainly wouldn't be giving anything else at that point. I'd be staying away from any opiates, anything like that. And I think at that point, certainly Entonox is adequate for that purpose. I wouldn't be giving anything sort of IV or paracetamol.
Perfect.
So, yeah.
I think that answers all the questions. That is everybody up to date. If you do have any questions and you haven't had time to get them in, then you can simply drop us an email. You will get a feedback email tomorrow with a copy of the recording on. If you have any questions, fire them to me to that email address from myself, and I will forward them on to Amanda, and I'm sure that she'll answer them in due time.
Could I just say one last thing, Andrew, before we finish? So just to sort of say to everyone, I put it on the front of the presentation, but there is, I run a Facebook page, which you're welcome to go on and follow or have a look at some of the information. It's paramedics and midwives, and it's called Pre-Hospital Maternity Training. And I've posted a really nice breech video on there for you, I think it was last week, and it's a really lovely normal breech birth, so that you can help start getting a consciousness of what that normal looks like. So I hope that's helpful for people. Yeah,
again, the website is on the front of the presentation for the Facebook page. What was the website again? Just spell it out for us, Amanda.
Yeah, so it's if you go on Facebook and you look for pre-hospital, so pre-hospital maternity training, and it comes up and you'll see a lovely picture of some of our paramedics sitting in a birthing pool, and if you've got that picture, you're on the right page. And by all means, do follow us. I run it with one of our advanced paramedic practitioners. We were doing filming yesterday for the London Ambulance Service about how to support breech birth, so you'll see a nice picture of our simulation mannequin on the front there. So please feel free to go on, please feel free to share your experiences, and yeah, any more questions at all, you can always put them on there for me as well.
I've just sent everybody a link to your Facebook page, so hopefully
thank you.
Everybody should have that now. Sometimes it amazes me, this technology, what I can do with this webinar software. But you should all have that link now. You should have it popped up in your chat box or your message box, and you should be able to see that on your screen. Okay, if I just quickly pop back to my screen, and I will tell you what is coming soon. And so, for those people who are members of CPD and who use us, your certificate and recording will automatically appear within your portfolio within the next 24 hours. All we ask that is you go in there and reflect upon your learning tonight and just describe how this might influence or change your practice for the future. And so it will drop into your CPD dashboard, and you can go in and edit that and change it. Some webinars again coming in July. We've got a gentleman called Paul Gowans, who's a consultant paramedic, and he's talking about professionalism and walking the walk. We all know about professionalism and how it affects us both while we've got our uniforms on and also in our personal life. And so Paul's going to talk about the constraints of professionalism. And that's going to be a good talk. I know Paul is a fantastic paramedic, and I'm sure he'll do a great job. And surprise, surprise, Amanda makes another presentation on the end of July. For me as a paramedic, I can never get enough maternity teaching, and so Amanda's coming back to talk about the cord is hanging out on the 27th of July. And we just have had a confirmation tonight that on the 28th of July, there's also going to be another webinar on human factors and design, and so that should hopefully quench your thirst in July for free great webinars. I always have to think about saying that. For those who want to have a look at what else is coming soon, just simply go on to cpdme.com/webinar. And as always, the webinars are free to attend. We've managed to find some great speakers like Amanda tonight who are willing to spend their evenings and teach us the best practice. All that leaves me to say is, Amanda, thank you very much on behalf of everybody who's turned up tonight for us. It's been a really useful webinar for me as an individual, and I'm sure all the guys and girls who's joined us tonight would like to wish along with saying thank you for teaching us how to manage a breech birth.
Oh, thanks very much, and thank you very much, everyone, for logging on, and I look forward to speaking to you again soon.
And thank you very much, everybody, and no matter what you're doing for tonight, whether you're starting a night shift or whether indeed you're going to relax for the evening, have a great evening. Thank you and good night.